Introduce our next speaker. Professor Cathy Chung is a consultant paediatric endocrinologist, and she's practising at Murdoch as well as at PCH. She's a clinical professor in the Division of Paediatrics. She specialises in the care of children with paediatric endocrine conditions and diabetes. She was previous president of the Australasian Paediatric Endocrine Group, and she's a member of the Council of the Endocrine Society of Australia. She's published widely on growth hormone therapy and participated in a number of international perspectives on growth hormone therapy and the management of children with short stature. Currently, she's also the chief investigator with the Associate Professor Jenny Downs, who has initiated a national registry evaluating the health outcomes of children with Prader Willi Syndrome and their families in collaboration with paediatric endocrinologists across Australia. Dr. Chung is the lead endocrinologist for the Childhood Cancer Survivorship Programme here at PCH. She enjoys national and international collaborations with other paediatricians and paediatric endocrinologists in both clinical and research initiatives involving paediatric endocrine conditions. She's also the chair of the Scientific Advisory and Safety Committee and a member of the Human Research Ethics Committee at PCH. And she has a real strong interest in the ethics and safety of paediatric research. And we're really so grateful to have her speak for you guys today. So I'd like to welcome Professor Chung.
I just have to make sure it's on. Yeah. But, so I'm not sure how I make this. How does it work? Do that, yeah. So thank you very much for having me and inviting me, Dr. Derek and others. This is a talk that I had to think about a little bit to make sure that I gave you what I thought might be a balanced view in relation to some of the treatments for individuals who have Noonan syndrome. You've already had some background to it, and I apologise being a little late this morning, but I will aim to briefly summarise some of the pathophysiology in relation to the Noonans, and then review some of the endocrine conditions that individuals who have Noonan syndrome may have, and then in particular discuss growth hormone treatment for short stature in these children. So as you already know, that it is in fact a quite common condition, and that it in fact does affect both males and females, and that it can occur across all ethnic backgrounds. It's autosomal dominant and has been possibly associated with advanced paternal age, as is similar with a number of other conditions, and it may occur in some individuals as a de novo, and I'm sure a number of you have children who are de novo. You have had substantial discussion, I think, around the variants that are clustered to this condition of the Noonan syndrome, and the features can be very mild or much more severe, and it's understanding the spectrum in children, which is very important for a clinician having some role in management or treatment of some of their health conditions. So, as you know, the more common one which we see is the PTPN2, and you have already talked about it presumably, and it is a critical component of a major signaling pathway where the external environment and then the hormonal environment and the growth factors, the cytokines, etc., transmit their information to the cell nucleus and tells the cell nucleus what to do and what other proteins to make, and therefore interact again with the other cells and then the organ and have an effect on the organism or the human. This is called the protein kinase pathway and deserves quite a lot of consideration as we move forward towards more precisely targeted medicine. There are still quite a number of individuals who do not have identifiable genetic variants, so they cluster to the phenotype of the Noonan syndrome condition, which a number of you will be very well aware of it. We just rehearsed here briefly the heart defects, and as you know, there are some skeletal changes in terms of the variation in the way the chest is configured, and in particular the curve of the spine, and that's quite important subsequently in trying to figure out, whether or not an individual would benefit from growth hormone treatment. As you know, there are components in relation to the neurocognitive component of individuals, and there is some who have a mild muscular hypertonia, and I know you've already discussed that, and there are some delays in sitting and walking and talking in a cohort report on this. As you are well aware, some children just do it right on time and therefore in fact are not recognised till later on when something occurs, particularly around their stature, and others are indeed delayed. Some children who I have met and looked after have very severe intellectual delay and disability, but others are very mild indeed. And similarly, there are other elements that we need to think about in looking after a whole child and making sure that, as with other children, that they can see and hear. And there are some auditory specific conditions associated with that. We have a role in, as an endocrinologist, in relation to the pubertal presentation of this condition and how it tracks through an individual's development, adolescence, transformation through childhood, adolescence, and then into young adulthood. Important that although there might be some primary testicular dysfunction affecting some children, it's certainly not all. So, and in particular for females, the fertility may not indeed be impaired. There are other urogenital sorry, I'm just fiddling here, urogenital conditions which we always have to have a quick look at and tend to scan for, mostly relatively easily done by doing an ultrasound of renal when I first meet a child, or look at that in terms of where it's placing. So this is from the APEG Hormones in Me booklet series. At the moment, we don't actually have one for the Noonan's condition. We do have one for Klinefelters and Turners, and I am creating with our Prader Willi cohort and families and other endocrinologists one for Prader Willi. I think they're quite good, and this is a background on how it starts. And the booklets are actually developed through the Australasian Paediatric Endocrine Group, and do tell you a little bit about the hormone system in brief, and sometimes I refer my medical students to it so they can kind of figure it out, at least that the anterior pituitary hormone is at the front and posterior at the back. And so we are, as endocrinologists, always concerned about this particular area, how the thyroid works, how the adrenal works in relation to stress, what is the interaction of growth hormone, is it sufficient, and does it work to the other parts of the body in different areas, and in particular, how is it measured in terms of a integrated value, so it's a biomarker. It itself has an effect on growth, and this is the insulin-like growth factor, which a number of you will be familiar with because they form part of the parameter for measuring growth hormone effects, growth hormone sufficiency and treatment. And then the anterior pituitary, which again sits behind that brain, is sending out hormone signals to tell testes what to do and ovaries what to do, and it is the timing of the presentation of these hormones, the LH and FSH, that develop into the pubertal progress and peak growth velocity. We don't usually consider the prolactin, but it does come out when a mother is breastfeeding and in other circumstances. So I think in relation to the growth and endocrine issues for an individual with the Noonan syndrome, it would be important that children are weighed and measured carefully, and there is some sort of surveillance at least for the first 3 years of life. And as you know, some of them are born small for gestational age as well, and so that is actually critical. And then subsequently yearly, as there is a shape to their growth trajectory over time. There is for those who have evidence of change in growth or deceleration in growth, that would be when usually the paediatrician or their general practitioner or even parents might self-refer in some form to a paediatric endocrinologist. The other condition to highlight, which we need to continue to monitor for, as you're aware, is thyroid function. Thyroid is a very important hormone. It deals with the capacity to it in fact does affect medium and short-term memory, and it is important for linear growth, metabolism, weight control. And the children themselves may not actually say, "Oh, Mum, I actually feel fatigue," or "My weight's going weird." They will be perhaps less attentive to their schoolwork or just feeling a little bit unwell. And certainly thyroid function done incidentally can identify hypothyroidism. But in general, with an individual with the Noonan condition, it would be reasonable to expect at least some surveillance of that through their childhood, maybe at, on a yearly basis if they're being seen by their GP or their general paediatrician, or perhaps if they're very well, extend that, because obviously you don't want to make lots of blood tests for individuals. The presence of the pubertal elements around the Noonan syndrome can vary a lot. In general, they are delayed, and that has quite some significance in relation to how one would approach consideration around their growth. But in general, there is a degree of delayed development, and sometimes we have to, as a paediatric endocrinologist, assist that and provide some androgen or estrogen to promote the pubertal or induce the pubertal events. Generally, therefore, just in sum, from a paediatric endocrine point of view, and it's not limited to this, but we use in an individual who has the Noonan syndrome, we will be considering growth hormone if there is indeed evidence for growth failure, thyroid hormone as replacement for hypothyroidism, and then consideration around the utilization of estrogen or testosterone for pubertal delay. So I think it's quite important to have a think about growth hormone, and so that you can conceptualize a little bit what is happening when we are aiming to treat an individual who has the Noonan syndrome with growth hormone. In some individuals, they do actually have a deficiency of growth hormone, and they are a small group, and their response to growth hormone is a little bit different. But most individuals do not have a deficiency of growth hormone. So growth hormone is produced in the body, and it can signal through a growth hormone receptor and interact and also speak to the liver, which produces IGF-1, which is, as I say, a biomarker, but also in itself a growth factor, and then it hits the target cells at the receptors. The reason why I put up this slide was again to emphasize the conditions around growth for individuals with Noonan syndrome, because it is really at this part of the bone which your endocrinologist will explain in terms of the growth plate. So a number of your children may have had a bone age, which is a wrist X-ray of the left wrist, and there they're looking at the development of the carpal bones and the growth plate in order to understand the maturity of the skeleton, because the maturity of the skeleton is important in terms of the length of time an individual will grow for and potentially what their final height might end up being. It is at this growth plate that the growth hormone and the IGF work, but it is also at this part where the interaction with the P10 variant or the other variants are affecting the capacity of growth hormone in the child's body to actually make the person grow longer. And so the reason why I bring that up is that it makes you understand perhaps how you approach growth hormone treatment in all children, and then specifically in an individual who has Noonan syndrome. So just to go back, we've got and this comes from Malakwe, who gives you a nice figure, and you can see here growth hormone talking to the growth hormone receptor, and then interacting or otherwise with the MAP kinase pathway, which is the RAS system, and then affecting the signal so that it either affects the effect of growth hormone itself, or if you replace these with IGF receptors, the same thing. So it changes the way the cell is able to develop other proteins and other building blocks for the human body to work, and in particular in relation to this stalk and its growth, but obviously there are other components including neurocognitive development. This is a slide from a piece of work that was done by Michael Ranke, who looked at 144 cases of children with Noonan syndrome that had been diagnosed in Germany. And what it is here is that this is the normal profile of an individual who does not have Noonan syndrome, and it's coloured in the kind of yellowish colour. That's for the females, and this is for the males. And in his 144 cases, what he did was he looked at them over a series of years, and he plotted their growth, and then he said, this is what happens to a person who has the Noonan syndrome. They have a growth that's a little different, and this is the Noonan specific growth charts that were created at the time. And you will see in this group that there are a number who are already quite normal in height, and you wouldn't necessarily contemplate growth hormone treatment anyway, because they're just moving along and they're normal in terms of their height. They're not necessarily going to be different from their children if you're looking specifically at stature. But the median number, which means the ones in more than 50%, will all fall slightly below that. What affects this display here, or in the case of any child that, and I'm now going across the normal range, is what the father's height and mother's height are, and then you can make a formula of that, and there will be, I'm sure, a number of you who will know families where all of them are short because mum and dad are short, and then all of them are tall because mum and dad are tall. So there is a contribution of parental height as well still to the Noonan condition. And again, here in the males, you can see, yes, certainly some individuals can be substantially smaller at 150. There is some bearing on their height, parental height, but the nature of their condition specifically does cause them to fall in the lower bracket across a cohort pattern of growth. The other element to take account of is the fact that the individual's puberty is delayed, and we know this is a specific issue with individuals with Noonans. And here we have what we would anticipate to be the normal growth pattern of children who are age 13. Everybody's seeing their kids just suddenly shoot up and get their, 7 centimetres, or in some instances 12 centimetres in that year. There are a number of children that will present who have a slightly late puberty, or in the male, a later growth spurt, and then in the female, presenting perhaps because she's not started menstruating or breast development is minimal, even though she's now 14. But one thing you will notice here is that the person who actually is usually a little bit later in their growth peak or their pubertal maturation will actually, to some extent, be a little later in finishing up with their growth. So you will probably remember a number of kids that seem a little small during your school years, or were the shorter ones in the footy team, and then you meet them, 10 years school reunion, and they're all pretty good heights. These, you can see here, the individuals who have finished their growth at about the age of 16, whereas this individual here is growing on the slightly lower, more delayed puberty, is still growing at 16 and doesn't finish till quite some years after that. And this is a pattern that affects a lot of the children with the Noonan syndrome and adolescents. This is an important study It is a very small study, and it was published in the Journal of Paediatrics. And the reason why this study is important is because they took the number of people they could contact out of the initial Ranke study, and they asked them if to sort of come back to them and talk to them, and etc. And they had a very small cohort of 44 of them out of the 144 that didn't get growth hormone treatment. And they asked the question, what happened to you in terms of your height? There are other components in terms of the health and quality of life in that particular report. But what they did find was that there were some individuals that actually achieved quite a normal height, 180. In the girls, it was even 165. So there are some individuals with the Noonan condition who actually end up with quite normal height and don't require any growth hormone. And a lot of these may indeed be individuals who had a later puberty and just kept growing, but they did sit a little bit higher on the Noonan's reference chart. So there is, just to summarise, catch-up growth, which may occur in late adolescence, that in general, when you saw those particular Noonan's reference charts relative to standard reference charts, there is at least a number that actually do achieve a height that is close to -2 SD. So there will be some that will still achieve a height that is at least where if you took a group of 100 males, they sit in the 5th, 4th, 3rd level for that whole 100 males. And similarly, there is a number of females. And in general, that there is in prepubertal children, at least about 83% are actually relatively small compared to their peers. But take account again of the fact that their puberty is a little bit delayed, and so that their final height may at least be counted for by the fact of and knowledge that there will be a later growth spurt. This is a piece of a report that came out of, again, a not very big cohort of Noonan's. It's not comprehensive, but it was a systematic study around where these authors, they published it in 2015, took as many studies that they could find with children with Noonan syndrome where growth hormone treatment was utilised, and there were 23 studies, and they did not identify any RCTs. RCTs are where you have a direct comparison head-to-head with placebo, where a person has Noonan syndrome and the next kid doesn't have, who has Noonan syndrome doesn't get growth hormone, he gets a placebo, so you might be injecting saline or something. And they excluded a number of these related to who were actually just case reports, and some of them had very short follow-up. So these days, when we're looking at growth benefit, we're usually looking at follow-up times that are longer than 3 years. And what they did identify here, that there was indeed an effect of growth hormone in children who have Noonan syndrome. The basis of that is important because in 2007 the condition of Noonan syndrome was accepted in the US and South America and some European jurisdictions for treatment for growth hormone, because they identified an effect of growth hormone despite not having growth hormone deficiency. In Australia, the PBS have very specific eligibility criteria for growth hormone treatment. So in some individuals who have growth hormone deficiency, it's relatively straightforward. They're small, you assess them for growth hormone sufficiency through a series of investigations that are done by the endocrinologist with the parents and the clinical team, and they identify that they're growth hormone deficient. And in those individuals, they get growth hormone therapy. Other children, and this is not only individuals with Noonan syndrome, there are many other children, they're not growth hormone deficient. We decided to check them for growth hormone or sufficiency or not. We can establish they're not growth hormone deficient. But if they're short, that means less than the first centile, and you'll remember from that cohort comparison, there will be a substantial number, and slowly growing, so they're growing very slowly. For the reference target control cohort, they would be growing less than the 10th centile, their velocity compared to other children. And on those basis alone, you, with careful measurements over a 12-month period, the Australian program allows you to have growth hormone. Those schedules are quite carefully structured, where the individual might grade up in terms of the dose of growth hormone. But in the background, just specific to Noonan syndrome, we do know that they tend to require a slightly higher dose, and these come from other studies that have actually reported dose efficacy for treatment for linear growth. This is an observational study. It was quite important. It's just been published, and it was dealing with 421 children who have Noonan syndrome, and they combined the American data as well as the Nordinet European data. And this is quite difficult to absolutely figure out, and even I took some time because I hate graphs. But anyway, what it is this is actually the pattern if you use the Rankine charts, which means that they move from they actually show an upshift in relation to where they would have been if they just followed without growth hormone on the Rankine. So you can see it starts here at baseline, which is below the 50th centile for that cohort, and they end up close to the first centile. These are really using it in terms of the national reference standard, which is for children who do not have Noonan syndrome, and this is where they've corrected for bone age. But in general, the main idea of this is to show you that there is a actual shift upward in relation to their growth centile, where they were originally sitting by the fact of the growth hormone treatment. The other element to be aware of is that there is actually an effect, particularly in that first 3 years of treatment, and that is not actually uncommon in relation to treatment of children who are not growth hormone deficient, in that the sensitivity to growth hormone is very much important in the first 3 years, and you can then see a slight flattening of the curve. So as a clinician, I often warn my patients, I say, look guys, you're going to get growth hormone treatment, make sure you give it for the first 3 years, because that's your best effect, that's the upshift. After that, in this one actually, quite interestingly, they identified that after 7 years it tended to plateau, so you didn't keep getting an incremental amount. Now that is affected slightly by the fact you can't just keep increasing the growth hormone. There is a safety limit and a particular for growth hormone, and also an eligibility limit, so that may play into the fact that they flatten out. So you don't just give them sort of mega amounts of growth hormone, you have to use a quite careful titration. In this particular study, they dealt, out of the 451, they dealt very carefully with the safety of the growth hormone treatment, and they had some serious events. This one here displays what they actually did have overall, and there was certainly some musculoskeletal events, but more importantly to note the scoliosis, which is obviously a very serious matter, because then the person has effects on spine and back for the long haul. They didn't have any side effects that ultimately affected their cardiac background, so individuals who did not make any of their cardiovascular issues, and in particular there is the risk for changes in relation to the primary cardiovascular event that the individual may have, and none of them reported any. There was some miscellaneous, and headache was quite common. This is important to note because it will speak to that a bit later in relation to the surveillance of individuals who have growth hormone treatment. So there is a important thing was the fact that they actually identified that there were some events which they attributed to the treatment with growth hormone therapy. So they were not able to absolutely say it was not related. And there they had they had 4 neoplasms or cancers in them, and they were, of those, there were 2 in the brain, and there was one in the spine and one in glioneuron. So it's actually part of the neurological system, the neuronal system, but it was not specifically placed in the brain. So there is, and this is in fact that and hematological malignancies, the common reported malignancies in individuals with the Noonan syndrome. So the conclusion was that this happened. They weren't able to absolutely attribute it otherwise or not to the growth hormone program, because you know that there's a 3.5 times higher cancer possibility in an individual with the Noonan syndrome compared to with an individual without. So it did conclude here that it was there is an underlying susceptibility, and that should be carefully considered and monitored throughout the growth hormone treatment. So, and at least for us, when we look at individuals who have any headache, we certainly get a percentage of individuals who have headache anyway when they get growth hormone treatment, because it's one of the side effects that are notable. It's called benign intracranial hypertension. Usually goes away when you stop the growth hormone. But in a person who has Noonan syndrome, you may take a more active intervention and get perhaps an MR a little bit earlier. So what did they identify in the general study, which is a real study where the clinicians who had treated these 451 individuals pooled the data? They found that if you're male, you're more likely to be presenting than a female. So, and that if you were female for the growth hormone treatment that you get, there was an upshift that did average at about 4 centimeters, and in a male there was an upshift where you looked at their predicted height versus what they actually gained of around 7 centimeters in that cohort. That in fact they do recognise again and probably emphasise the importance of treatment over the first 3 years, in that when you're treating a person with growth hormone, regardless of the age, to make sure that the treatment during the first 3 years is done properly, because that's when you get your main sensitivity and the biology around how the body reacts to a hormone after that time, and whether there are some pathways or signals that change with continued exposure to a particular growth agent is still quite a important field of study and not quite understood. They did identify in this that children that were younger had a better outcome and a better height, and that they thought that perhaps within that 455, and not all of them had their genetics done, that perhaps those with the PTPN2 actually responded a little bit better. So, there was only, however, a small group that achieved absolutely normal adult height, and those were the ones from the 50% lower in that Ranki cohort that shifted up. But at least 70% they felt shifted within the reference range, so they were about the 3rd centile. So they went from being well below the 3rd centile to being about the 3rd centile. So in that cohort, they felt that there was a benefit to growth hormone, and that there was no evidence to support a higher prevalence than was noted for the control population or individuals who had the Noonan syndrome per se. So that's the tricky part, because there has never been a head-to-head placebo versus intervention. So you can't get, in a rare condition, enough patients and participants to actually come to a conclusion. So you can only say, well, if you have Noonan syndrome, you've got a 3.5 times higher risk, and you need to be monitored for that. And then if you have growth hormone in that cohort, they had some with neoplasm identified, but it was only 0.7% of the whole cohort. So you couldn't say absolutely, although as a treating clinician, obviously you'd stop giving the growth hormone, but you wouldn't be able to say they couldn't absolutely attribute the episodes of neoplasm to growth hormone treatment itself. It does remind us that there's an increased risk, and that the physiology is within this mitogen activated kinase system, which is intrinsic to cancer, And then again, we've discussed that. So the question is, are there specific differences in susceptibility? Do we have enough available data on growth hormone to consider that it's completely reassuring? And have we in fact developed protocols at initiation of growth hormone treatment and ongoing surveillance that will allow us perhaps to capture any evidence for cancer early enough? And I think that that's an area that needs to have some collective guidance and information to be brought together. So this was one thing that I thought I'd field here. I do believe that family-based registries are helpful to provide ongoing information about a condition in a real-life way. And we mentioned the Prader Willi. We actually were very fortunate to get a foundation grant from the hospital to set one up, and so we have a national Prader Willi database, and in that we have the questions that we've asked of the families who fill the questionnaire in. They were formed by a little group of mums who said, these are the questions we want to know. And we've actually identified some important things that were not notable for the clinicians in the standard guidance. So I just bring up this idea because I know we don't have one here in Australia, and there isn't a big one unless obviously some of you know of one, and we happily look into it. But there is a good benefit from registries and clinics such as the one that maybe Dr. Derek's one was set up, where it becomes a resource and a cohort for identifying the needs of the children and the families, and specifically to, over time, to be able to get information that will perhaps quantify accurately the effects of treatment and the risks. And then to perhaps identify some of the strengths in the children, which can be enhanced as a cohort or looked to, and ones where we know, well, most of them are going to get this, and so let's do that. And then it may then allow us to draw something together to provide guidance for the clinicians and the families with children. It has some bearing in the Australian context because of the NDIS. So often there's a family will come even with the Klinefelters or any other syndrome, and they'll say, oh, doctor, what do we need, and what do you think, how do you forecast? And you can only say every child is different, but if you have collective data, you might be able to perhaps anticipate needs a little bit more actively. So that would be one of the future directions I would think would be should be considered in all of these rare conditions, and some of them are better developed than others. And anyway, thank you very much for your attention.
Yeah, we had a few questions submitted online. The first one was, there's been some research into lovastatin reducing cognitive deficits in my studies with Noonan syndrome. Do you know if this is an area of research that is being looked at with human trials at all?
There is only really one that's published in relation to it being on a trial site, the clinicaltrials.gov, which is the main site that we have to have any interventional trials published on, either that or the equivalent of the Australian one. So, you know, if you and it is the utilisation of the lovastatin or the HMG they are mainly in the NF1 cohort, but there is some in the Noonan's cohort. There is one specifically only looking at bone and growth. They've got fairly small 15, so they're really only, I think, in the pilot phase to look at the efficacy and safety in a very early phase trial. Nothing bigger than that. They're not open to, the one that was published on the site anyway, is not currently open for admission to Australians. I'm not sure, but there is another one where they have already reported some preliminary data that's coming out of Westmead. The co-authors seem to come from Westmead, so there may be more activity than we know of. But but they weren't specifically listed. What they did was they looked at mice. They knocked into the mice the PTPN2 variant into the mice, and they were able to characterize the mice as having spatial issues, which a mice has spatial issues, and then they were able to then give the statin. Statin is used, as you know, quite widely in the population, has a relatively good safety profile, and so it is a good trial to consider because it is relatively safe. Have to be a bit careful as a clinician. We're pretty careful with utilization of statin, because in the younger age group where there's bone growth, and that was potentially why they would have looked at it in bone, is because it also is a cell cycle inhibitor. So therefore, if you give a statin as a cell cycle inhibitor, person's trying to grow and therefore don't want their cells to be inhibited, then will that have any specific effects? So I think it's still in the safety phase, which is what we call the phase 1, rather than being in a phase 2 or phase 3 in general. But yeah, would obviously keep that in mind. One of the valuable things about obviously not only a parent support group, parent bodies with platforms such as national databases is with a governance structure around, you know, having maybe two clinicians and you know, 3 parents, and as what we have for Prader Willi across the different states, and they can say, well, this has come up, we've been approached by this sponsored trial, whatever, what do you think? And there is some structure around sending it out to the other parents in terms of, you know, you don't want to send out stuff that's truly wacky, but that is another way that these sort of registries and platforms may work. So that's an evolving space in the longer term now that we've got the capacity electronically to communicate and interact so well, that it would be one of the things you could consider in the longer term.
Okay. Yeah. Any questions? Yeah.
I have a couple of questions. So one is, do you foresee, like, the charts that you put up before, where they compare the Noonan's height and weight to the original, to someone who doesn't have Noonan's? Yeah. I could have this wrong, but it looked like they were done in 1988. Yeah. Do you see any more current ones, like a new test being done?
No, they haven't done a recurrent one, because a lot of them would have received a growth hormone, because those were in terms of their natural history. And I can go back.
Yeah,
that one. Yeah, so we haven't generated, there hasn't been a generation of a one where there hasn't been growth hormone treatment. But this is a very small cohort. It's for 144. It was done by Dr. Ranke, who later on has had a very strong sort of interest in the natural history of growth of many of the other endocrine conditions as well. But he took them from, and they were all from Germany, so I don't know how Germans grow, but I mean, it may be different in another ethnic group as well. And so I suppose things like registries where some parents may choose not to treat or to treat are actually good ways of informing, as long as the registry is kept properly and looked after and the data is clean and precise, then that can be quite helpful. But
so in order to get a new one of those done, a more current one, you'd have to have a larger group of children that haven't had growth hormone at all to get an accurate data.
If you're looking for individuals who have not been treated with growth hormone, but a lot of people will present to the clinician here. And if you're falling in this area where you're well below the first centile, then you know, they would potentially get some growth hormone, at least in Australia, to kick them up here, and that is something that should be considered quite carefully in terms of growth hormone and safety, is and the way to treat an individual with the Noonan syndrome condition, whether or not with those individuals who have a predisposition to a cancer, once you've clicked them up, that you wouldn't necessarily continue them, so that you'd allow their natural trajectory. Those sort of quite complicated ways of treating are not done here at the moment or anywhere else. Most people would treat to give the best effect for the longest effect, and so they would then treat till the bones are actually mature as a standard. There are different forms of growth hormone treatment which are coming through, long-acting growth hormone, and whether that's a more efficient way of getting growth hormone rather than injecting once a day, to inject it once a week. And also trying to understand the physiology of growth in a different way, where there might be different patterns of prescribing growth hormone, and they might emerge in the future. In order for those forms to emerge, it would be important to get quite good precision medicine, and so the genetic understanding, because a person with the BRCA1 variant will be very different from the PTP2 variant, etc.
The second question that I had was, a lot of your talk was on growth hormone that you have that increases your growth if you're small in stature. Does endocrinology do anything to put off or delay early puberty if they're starting to become like getting breasts and pubic hair, and they're going through that puberty stage earlier before they've reached height?
No, you don't tend to do that as much anymore. In fact, just in general for children, unless they are very, very advanced in terms of their puberty, we don't do that. And there's been some guidance from the US Paediatric Endocrine, as well as the Growth Hormone Research Society, which is one of the societies, the international one, which I'm part of, and have actually written some of the guidance. So we don't tend to delay puberty unless it's really forward. So that means a person that bone age is actually 12 when they're only 8. That's when you would consider it. But this does not apply to the Noonan person. The Noonan's person actually has a delayed puberty, so their puberty is delayed, so you wouldn't actually contemplate stopping their puberty.
Yeah, my daughter has, she's got the SOS1 gene. She's just turned 10, and she's quite advanced in that she's got pubic hair and starting to develop breasts, and she's got the body odor and things like that, and she's only just turned 10 like a week ago. So I'm worried that she might be, and she's still very small in stature, that she's developing too early in the pubic stage.
There's in general the guidance is not, but you do have to be quite specific for each individual, because as I said, some are severe in one area and not in the other. So, and each different condition of the Noonans is different. As I say, we're looking after a boy with the BRCA1 variant, and that's very different from all the number of the children I see with the PTPN2. So I wouldn't say no to anything, but just need to think of it in terms of principles of treatment, plus really in terms of the benefit that they may or may not have.
The other, just last question that I had was, do you think that it's beneficial for all parents that have children with Noonan syndrome to see endocrinology just to get a baseline check, or do you think that we only need to go to endocrinology if we're referred by a paediatrician?
It really depends on basically the health server and the health service. There's general paediatrics is the best and most important platform, because it aims to look at the other elements of and bring in resources around the wider components of Noonan's, because we would be specifically looking at the hormones and the implications of hormone treatment and in terms of timing of testosterone, in terms of how obstreperous your kid could get when testosterone clicks in, those sort of things. You do manipulate that a bit. Sorry.
Yeah, I can answer that question as well. I'll just do that quickly. So generally we do the monitoring of growth and puberty and looking for hypothyroidism, all of those sort of endocrine assessments as part of the holistic time where we see kids under 6 every 6 months and over 6 annually. If the parents wish endocrine referral, we would often give it and discuss the merits of it there and then. Of course, we don't want to overwhelm them with stuff that we know that they're not going to be doing any intervention with. So that's the answer to your question. It's definitely to bring it up with your general paediatrician. And of course, there are in other sites general paediatricians looking after these cases. We don't want to take over the care of everyone. But what we're trying to do in our rhizopathy clinic is start registries. So we've been working on 2 big registries, one for neurofibromatosis and one for Noonans, and they're both registered. But there's been an ethics issue, not with data capture, but between who owns the registry. So at the moment, we're busy working through the ethics applications of how to look after that registry. So everyone who is having that diagnosis will be invited to be part of that registry, and I assume that it's going to happen before the end of the year. Jackie's working on it at the back there, and we are making some progress in the area. And I've also interested in other aspects of Noonan, so that will be a place where we can get information for other things. My personal interest is ADHD, autism, and developmental delay, so I'm interested in looking at this cohort of people to see how we can help them better.
Yeah, I definitely agree. I mean, the Prader Willi registry is constructed with endocrinology, but big players are the sleep and respiratory physicians and also the developmental paediatricians. They're across Australia, that particular registry, but conceptually the general paediatric background is really, really important to anchor the process. And I mean, one, obviously, if you have a long interaction with many of the children that we have, and I start seeing them, I come in and see them and then give them a hug when they get up to their 16th birthday. But I think that you bring to that understanding around their development and the hurdles that they have, and you do sometimes have to write up, some requests around thyroid or something to a school. But the general paediatric service, which actually deals with or a clinic specifically directed to the cohort, would be good. It allows it to be a resource, so that if parents decide to, go privately or use other systems, they can keep dipping back in and looking at what might be upcoming. Yep. Great. Thanks very much.
Thanks, Cathy. Thanks.